One manifestation of Staph aureus is staphylococcal scalded skin syndrome, and that's what's shown in this image here. So what you're seeing is that the production of the exfoliative toxin causes layers of the tissue to come off. This is a child, and this is you can see it's their bottom. And the reason it's called scalded skin syndrome is it looks like the child has been scalded. And so there were times where people were having like Child Protective Services called on them when they took their kids to the hospital because they're like, you put your kid in boiling water. And that isn't actually what happened. It's the bacterial infection that causes the layers of tissue to dissociate. That same type of toxin can also cause something called bullous impetigo. So you have these kind of fluid-filled blisters where, again, you get that tissue lifting and then fluid can go in between them. We can also see staphylococcal food poisoning. This is going to be really common with things that are salty because staph loves to grow in salt, which is why it does really well on your skin because your skin is salty. So this is a report published by the CDC in their Morbidity and Mortality Weekly Report that illustrates many of the important features of staphylococcal food poisoning. So 18 people attended a retirement party and became ill 3 to 4 hours after eating. So this is something that's really important to note. If a patient becomes sick within a handful of hours after consumption of food, we are almost certainly talking about what we call an intoxication. There was preformed toxin on the food, and that's what made the person sick. This is almost always not an infection because infection requires the bacteria to get in the body, to colonize, to produce enough bacteria, to produce enough toxin to make people sick. And that usually takes at least a day or two. So if a person is sick within 3 to 4 hours, it's an intoxication. One of the other things is that nausea and vomiting are really, really common with intoxication. Vomiting isn't as common with infection. That's going to be mostly diarrhea. But the toxins that cause vomiting can also cause diarrhea. Hardly anybody had fever or headache. Remember, fever is also a symptom of infection, but not necessarily intoxication. And the symptoms lasted about 24 hours, which is, again, about how long it would take for the toxin to get out of the body. Whereas if it was a bacterium, it usually takes longer. The illness was associated with eating ham, something salty. A sample of the ham was positive for staphylococcal enterotoxin type A. So whoever made the food, they made it at home, took it to work, sliced it while it was hot, and then refrigerated it. And the ham was served cold the next day. Cooking the ham killed the Staph aureus, so it's unlikely it was contaminated after it was cooked. So it's likely the ham was contaminated after it was cooked. So probably when she was slicing it, bacteria from her skin got on the ham, and then as it cooled, the bacteria were still there. The delays involved in refrigerating the ham and the fact that it was stored in a single container allowed the organism to proliferate and produce enterotoxin. So type A is the most common with human disease. Rapid onset and short duration, nausea, vomiting, diarrhea, typical of the disease. Care must be used to avoid contamination of salted meats such as ham, because I know it was served cold and you're like, well, maybe if they had just heated the ham, it would have been fine. Nope, this is a heat-stable toxin. So the toxin was already there. You could heat that ham all you want, but the toxin is not destroyed by heat. You're still going to get sick. So staphylococcal food poisoning, we don't often think of staph as a food poisoning agent, but it definitely can be. So on the next slide is going to be kind of a graphic picture. Unfortunately, it's a medical microbiology class. We are going to see things that are graphic. This is a patient who had Staphylococcus toxic shock syndrome. So this is a picture at autopsy of a patient who died of toxic shock syndrome. So in 1978, the first investigators described a pediatric disease they called toxic shock syndrome. A 15-year-old girl was admitted to the hospital with 2 days history of sore throat and a vaginal infection associated with vomiting and watery diarrhea. She had a fever and low blood pressure and a rash all over her body. She had acidic blood. She had proteins in her urine. She had disseminated intravascular coagulation. Basically what that means is you have these tiny little blood clots forming throughout your whole body. And when they do that, your blood can't clot anymore because it's formed all these tiny little blood clots. And so you can start to bleed when you're not supposed to bleed. She also had infiltrates in the lungs. She was admitted to the hospital in the ICU, where she was stabilized and improved gradually over a 17-day period. On the 3rd day, desquamination started on her face, trunk, and extremities and progressed to peeling of the palms and soles of her feet by the 14th day. So basically, like, her skin was coming off. All cultures were negative except for from the throat and vagina, from which Staph aureus was isolated. This case illustrates the initial presentation of toxic shock syndrome, the multi-organ toxicity, and the protracted or elongated period of recovery. So anyone who's ever used a tampon, or if you've purchased tampons, or now if you're curious and you go to the store and you want to look at a box of tampons, it tells you not to leave the tampons in for more than like 3 to 4 hours, because what was seen a lot in the 80s and 90s was female patients who would show up with toxic shock syndrome associated with tampon use, because the tampon, as it's inserted, can cause microabrasions in the tissue of the vagina. And if there's any sort of Staph aureus like on the skin that's on the tampon, and then it gets into those little microabrasions, that can cause the systemic infection. And so this toxic shock syndrome toxin is a super antigen. And what it does is it leads to the overstimulation of the immune system. And there have been some studies that show these toxic shock syndrome toxins can stimulate up to 20% of T cells in the body. So then you get that cytokine storm, that septic shock, like we talked about in the immune system. It's estimated that 90% or more of adults have antibodies to this toxin, meaning that we've probably all seen it before, but luckily it didn't make us as sick as it can to some patients. And as we can see in this image, this infection can be fatal. We typically think of Staph aureus infections as cutaneous infections or skin infections, not of the your skin falling off variety, but more of like wound infections. And so you can have impetigo. This is dry impetigo, which is shown here. It doesn't form those big fluid-filled blisters like the bullous impetigo. Folliculitis, or these are kind of fancy words for boils. So basically, like wherever you have a hair follicle, it can get infected. If you have multiple, they can kind of merge into a giant boil like this on this. I'm assuming this is a male patient on his butt. And then, of course, wound infections. We also can see systemic infections with Staph aureus. And the toxic shock syndrome is not necessarily a systemic infection. You could have, like in this case, the patient had a localized infection in the throat and in the vagina, but was experiencing systemic effects because of the production of toxin. When I say systemic Staph aureus, what I mean is the bacteria are traveling throughout the body. So bacteremia, which is basically bacteria in the bloodstream, and endocarditis, which is an infection in the heart. These are not terribly common, but they can happen. So here's a clinical case of endocarditis. A 21-year-old woman with a history of intravenous drug abuse, HIV, and a CD4 count of 400 cells per millimeter cubed. I know it's kind of a weird unit to talk about, like a volume, but it's kind of how they do it. So this means basically she's not progressed to AIDS yet. This is high enough that it's not AIDS, but it's not super high. So you want to have more CD4 positive T cells than this. So she developed endocarditis caused by Staph aureus. 1 week history of fever, chest pain, physical exam revealed a heart murmur. Bilateral lesions were observed by chest x-ray. Cultures of blood and sputum were positive for methicillin susceptible, so she's lucky, Staph aureus. It's all over her body is basically what we're saying here. The patient was treated with oxacillin for 6 weeks with the resolution of the endocarditis and the lung abscesses. This is acute onset Staph aureus endocarditis, the risk factor of intravenous drug use, and the complication of septic emboli, those infection in the lungs. Systemic Staph aureus can also cause pneumonia, osteomyelitis, so like bone infection, and septic arthritis, so infection kind of in the joints too. So I want you to think about, how do the bacteria spread from the skin to the internal areas of the body? So how did this patient, or how does any patient get the bacteria from their skin into their body? Very briefly, I want to talk about the Coagulase-negative Staphylococcus species. So this is basically everybody but not Staph aureus. With the Coagulase-negative Staph species, we tend to see them mostly again in patients who are already compromised as a nosocomial infection, an infection of catheters or shunts or prosthetic joints, so things that didn't really belong in the body but got put in the body. And then, of course, endocarditis and UTIs. So this is a different staphylococcal species and how it causes endocarditis. Native valve endocarditis, which is Coagulase-negative Staph with a predilection for causing endocarditis. 36-year-old woman was an active cocaine user who presented with acute onset of weakness on her right side. Fever with chills, tiredness, shortness of breath over the preceding 10 weeks. Just as an aside, those of you who are going into medicine, I mean, it might be like, you felt sick for 10 weeks. Why didn't you go to the doctor? Well, one, in the US, like, people don't have health insurance always. So that might be why they didn't go to the doctor. Or two, they're cocaine users and they know that they're going to be judged for being a drug user, right? Or for whatever reason. So what's really important for you as a physician is when you establish a relationship with a patient, you know, if they show up to the ER, don't be judgmental. If they use cocaine, they use cocaine, but you still have to treat them. And you don't want to treat them poorly because they may never come back. If they've been sick for 10 weeks and never came in, don't shame them about it. Encourage them to come in earlier next time. Okay, she had a high heart rate, low blood pressure, fever, heart murmur, CT scan. She had a large infarct, basically area kind of with no blood supply in the left basal ganglia. 4 sets of blood culture were positive for that Staph species. The isolate was penicillin resistant, but susceptible to everything else. Pretty much everything is penicillin resistant, so whatever. Patient had a penicillin allergy anyway, so they started treatment with vancomycin and gentamicin. So you see this double kind of barreled antibiotic, 2 different mechanisms of action. This is a pretty significant infection, so going for 2 is usually better. Patient became afebrile, so their fever went negative at 3 days. Blood cultures after that were negative. Gentamicin was discontinued after 1 week, but they continued with vancomycin for 6 weeks. Over the next 7 months, the patient developed progressive mitral regurgitation that necessitated mitral valve replacement. So basically the heart valve was damaged so much that it had to be replaced. This is one of the more virulent Coagulase-negative Staph, and it can cause more common issues in a native heart valve. So again, sometimes with the endocarditis, you see it in an implanted heart valve or a heart valve replacement, but this one will cause it even without a heart valve replacement. Persistent bacteremia is characteristic of intravascular infections such as endocarditis. So again, these are just things that you need to look out for as a clinician. So how do we diagnose Staph in the lab? Microscopy and nucleic acid tests are usually very helpful. Culture is great. There's a type of medium called MSA, mannitol salt agar, which tends to grow only staphylococcal species. So it's selective for staph, but it's differential because Staph aureus will turn yellow, whereas the other staphylococcal species will be white, or you'll see them kind of as the same color of the plate. Most Staph aureus species are also beta hemolytic. So if you grew them on a blood plate, you would see these zones of inhibition. Staph aureus, so this comes from the Latin for gold. So that's the yellow color. So this is an MSA plate where Staph epidermidis, you see it grows, but it's not like, not really a color. The Staph aureus, it itself is yellow, but then it also ferments the mannitol, which turns that yellow, and then that's your control. You can also test for microbial surface components. They're called M-scrams, microbial surface components recognizing adhesive matrix molecules or antibody production. But oftentimes this type of plate is really all you would need to diagnose that it's like Staph aureus versus another staph species. Then what you need to do in the lab, which I think, once you know that it's staph, what you need to do is figure out, is it resistant to antibiotics? Most strains of staph, like 90% or more, are resistant to penicillin. And then with Staph aureus, of course, we're seeing methicillin and vancomycin resistance on the rise. One of the other things you would want to do as a clinician is drain and clean any abscesses to physically remove the infection. Proper wound healing and disinfection will prevent most infection. But spread is difficult to control. And I don't mean spread like within the person's body, but I mean spread from person to person, because so many people are asymptomatic carriers. So physicians are asymptomatic carriers, nurses, patients, visitors, everybody that goes in the hospital is pretty much an asymptomatic carrier. And so you're going to have that spread throughout the hospital setting. And then, of course, we have our antibiotic resistant Staph aureus. So some of our sections will have a picture like this of from a CDC report on antibiotic resistant threats. So methicillin resistant Staph aureus, they have 3 levels of threat. Serious is like the middle level of threat. So here, estimated 323,000 patients who were hospitalized also developed a methicillin-resistant Staph aureus infection. 10,600 deaths in 2017. $1.7 billion in healthcare costs. And again, this data is only from the US. So if you want to go worldwide, it's even worse. Staph aureus is a common bacterium that spreads in healthcare facilities and the community. Methicillin-resistant Staph aureus can cause difficult to treat staph infections because of resistance to some antibiotics.